Reports from the Health Department, and welcome to the June Board of Health meeting. Today we're going to have presentations from Misty Lechner on the food system assessment, Teresa Fisher on the fetal infant mortality review, Ed Kalis more about the mosquito surveillance, and then Dr. Pizzino will talk about the county health rankings. So is Misty here? Misty here? Okay, she's down the hall. They just went to grab her, so we'll be starting in just 2 seconds.
Okay.
I'm sorry. Okay, yeah, Christy's here. I think they're just coming down the hall. I'm going to go ahead and... There they come. So we're ready for Misty to come on up. She's going to start us off, and her presentation is ready to go.
Hello, good morning, and thank you for having me. I am here to talk a little bit about the community food system assessment that was completed by Heartland Healthy Neighborhoods over the last few months. My name is Misty Lechner. I am the Advocacy Project Director for the American Heart Association, focusing on healthy food access in the state of Kansas. I also get to act as the chair of Heartland Healthy Neighborhoods. And Heartland Healthy Neighborhoods is a community health coalition covering Topeka and Shawnee County, and we have over 100 partners and have been around for about a decade. So the next few steps will provide you a little bit of information, just an overview of Heartland Healthy Neighborhoods, just to remind the group a little bit about the process that we took to do the community food system assessment, a few results, and then kind of the next steps. Where do we go from here? So Heartland Healthy Neighborhoods has a number of work groups. Healthy eating, active environment, which is our physical activity and built environments that support physical activity, healthy babies, or our fetal infant mortality review board, access to care, and transportation to health care. Communities of care, which assists in transitions of our Medicare population out of the hospital back home. WorkWell Shawnee County, which focuses on worksite wellness, and our Health Equity Exploration Group. It is the Healthy Eating Work Group that received this funding from the Kansas Health Foundation to complete this scope of work. And this project started last summer, where we really took a hard look at what do we need to know about our food system here in Shawnee County. And quite frankly, we started the process of engaging a lot of voices that we hadn't in the past. We worked with Barb LeClaire with LeClaire Consulting to compile all of the existing data. So there's all kinds of data from the Department of Health and Environment all the way to private data on food retail and sales. Then we gathered some community input and feedback, and that is where we actually scoured our Rolodexes, called up our partners, and asked them to call up their partners and said, who do you know that is invested in food, farming, and the economy here in Shawnee County? And we gathered input from dozens of people. We actually worked with K-State's Center for Civic Discourse and Democracy, and they were our neutral facilitator for our community feedback events. We actually used a tested and validated model to gather feedback known as FEAST, which is Food, Education, and Agricultural Solutions Together. This is a model for gathering community information and feedback that's been used around the world. So we knew that this would be a model that would work here as well. So we paired all of that community feedback with that data that we compiled through Barb LeClaire to really come up with a plan that works, that's both based on evidence and based on community needs and feedback. And now the next step is sharing those results and taking action. So I will bring your attention, and if you need a copy, Craig Barnes has a copy of the Community Food System Assessment and one-pagers that we developed. So we have 77 pages of data, and we have 11 pages of feedback. So as you will see, that is a lot to digest. So what we did with that full 88-page assessment is break it down into something that was a little bit easier to comprehend. So we took all of that data and separated it out by sectors of the food system. So there's one page on food production that really focuses on the agricultural sector of Shawnee County. One on retail that focuses on what is actually for sale, what do people buy, how much do people spend. And then other things like the economic impact, food processing, and even equity in our food system, for a total of 9 one-pagers. So the process that we took was making sure we had all of those voices. As you can imagine, as Heartland Healthy Neighborhoods, we have a lot of health voices that we engage on a monthly basis. But what we needed to do is really make sure we had farmers, we had food processors, we had business, and all of these people working together and providing their voice. In all, we had about 50 people attend our events that we hosted in January and February. And we had dozens more engaged through email, telephone conversations, and other one-on-one and HHN meetings. We had a list of about 130 people in total that we engaged in this process. We ensured we had data and feedback all across our food system, from research to the Shawnee County Farm Bureau, to Insane Pain Produce, a fruit and vegetable producer here in Shawnee County, Hy-Vee, Grace Med, and even our Topeka Sustainability Advisory Council. So we knew waste management was something that was also being considered. Not only did we invite people to ensure representation across this food system, but we also invited a people based upon a range of other factors, including income, education level, race and ethnicity, geographic location within the county, and also other backgrounds, expertise, or experiences that they may have. So I won't hit the data too hard, but I wanted to share with you a few points that stood out to us, because this has really helped form our vision. So first, I wanted to share agriculture and food actually contributes $2 billion to our economy here in Shawnee County alone. All of this is county level data. So that's a huge economic driver. And not only that, but food processor is a large chunk of that. So our processors like Research, like M&M Mars, like Frito-Lay, they contribute a lot to that $2 billion. We have 826 farms in total in Shawnee County. And that's fantastic. A few things that stood out, though, is the average age of our farm operators are 60 years old. So we need to consider transition plans for those businesses to a younger generation as that generation starts retiring. Net farm income averaged a little over $22,000 a year. Also, 51 million pounds of food are wasted every year in Shawnee County. So at the same time those 25,000 tons of food are wasted, we've got 27,000 families that actually struggle to get enough food. Also, at the same time that obesity is increasing in Shawnee County, only 17% of our food budget, which is known as about 89 cents a day, is spent on fruits and vegetables. More than 1 in 7 households struggle to get just enough food to survive and eat. And so if they're focusing on getting just enough food, they're not focusing on nutrition and the kind of nutrition they need to survive and thrive. As I'm sure everyone is aware, we've had 3 grocery stores close in the last couple years. That leaves 31,000 residents of Shawnee County without easy access to the fruits and vegetables that would normally be for sale in those grocery stores. And across Kansas, about 48.6% of students are eligible for free and reduced price lunches. So that means that they have to have an income below a certain level to be eligible to apply for that. So with 48% across Kansas being eligible, in USD 501, that is 79%. And not only that, but the overall rate in Shawnee County for kids who are eligible for free and reduced price lunches has increased by 11% in 8 years. So that's a trend that's alarming that we considered as something that was important that we should do something about. So what does this mean and what did we learn? Now that we have those hard numbers, that only tells part of the story. So through these events, what we learned is our community is really proud of what we're doing well. And we want to shout that from the rooftops. And not only that, But we have a lot of really strong partner organizations here in Topeka and Shawnee County that just want the platform to collaborate and do something more. They are proud of these strengths and they want to build upon them. We also learned that these issues, changing an entire food system, it's complex. There's a lot of facets to it. And it's hard to wrap your head around because no one organization really owns food system work. So as a result of those things and keeping those things in mind, what we recommended is that we have a process to review the impact of local policies. That's zoning, that's regulations, that's other policies, to see what their impact would be on health, hunger, agriculture, and equity in our food system. We also want to develop healthy guidelines for food served in public places. So when our families and children go to places like public parks or pools, they actually have access to some healthy options, and it's not just things that would decrease their health. We also would like a development of a food and farm council. This is something that Heartland Healthy Neighborhoods and all of the partners that were engaged with this whole process are really interested in helping with, in developing resolutions and bylaws and guidelines that this Food and Farm Advisory Council can work with you all to help establish. So look for more on that later. And then also strategic investment in a community health planner position in Shawnee County, because no one really owns the work, but there can be a planner to help guide the work of these organizations toward our common goals of improving health, nutrition, agriculture, and the economy in Shawnee County. So our next steps is we would like to share this information, these resources, more, both locally and beyond that, because not all of these recommendations are in your hands. Some recommendations are in the hands of county residents to advocate and educate themselves. Others are for our state and federal lawmakers as well. So we're in the process of educating them on what they can do to impact our food system here in our community. As I mentioned earlier, our partners that were engaged in our community feedback events, as well as in Heartland Healthy Neighborhoods, would happily help in the development of a food and farm council. We've got a number of entities that are already interested and engaged in developing this. And then finally, we would like support for a community health planner, because volunteers and community organizations are great, but we need someone to be our guiding light to keep us all moving in the same direction. And this is the motto of Heartland Healthy Neighborhoods, which I find to be quite nice on a day like today where I'm sharing this data. Coming together is the beginning, keeping together is progress, and working together is success. We have come together, we have developed this assessment, which is our action plan for food work for the foreseeable future. We plan to keep together to develop this advisory council on food and farm issues. And all we need to do is continue working together, and I know we will see success, and we will happily work with you to see additional success. And that success through decreased hunger, improved health, improved environmental sustainability, and increased overall impact on food and farm businesses in Shawnee County. If you have any quick questions, I will happily take them now, and I will also be here throughout the duration of the meeting.
Very good, thank you.
Thank you.
Questions for Misty?
Yeah, well done.
Thank you.
There's a lot of information contained within the assessment.
Thank you, Misty. Okay, next we'll have Teresa Fisher come and tell us some information about the fetal infant mortality review.
Good morning. I am Teresa Fisher with the Health Department, and today I'm here to provide some general information about our Fetal and Infant Mortality Review Program, otherwise known as FIMR. I've had the opportunity to serve as the project coordinator for this project for the past few years, and hopefully, we'll give some general information about the project and how the project works here in our community. All right, let's go here. Okay, so one might wonder, besides just the fact that infant mortality in general is an important thing, but when we look at the health of our community, it's a really important indicator. And so this is something that oftentimes when communities are getting different scores on and different things of that sort, that this is an important indicator in a lot of meetings. And it's important for our community because unfortunately we've had a high infant mortality rate. Briefly, how infant mortality is defined. The infant portion of it is defined as the death of a child less than 1 year old. The fetal portion of it is defined if a mother reaches at least 20 weeks gestation in her pregnancy. And so it used to involve a certain amount of weights, but that is now gone. So as long as the mother reaches 20 weeks or greater, that's considered fetal mortality. And then the actual infant mortality rate, it tells you there, it's the death of children less than 1 year of age per 1,000 live births. And that's an important statistic to remember as we move forward and look at a few other statistics as far as how that information is derived. The causes of infant mortality, there's several causes listed here. There's some known physical causes, but I would draw your attention to the social and environmental factors. These are really, really complex causes, and the more we study infant mortality, the more we learn that it is a complex process, and it's deeply rooted in a lot of these areas, and unfortunately, it's not something that we can pinpoint to be exactly one cause and fix it. Otherwise, we would have fixed it here in our community. The more we learn about it, the more we understand that these are really, again, deeply rooted issues and things that are going to take a long time to fix and understand. This map is a little bit hard to see. I apologize for the smallness of it, but basically, just to draw attention, Kansas is at a higher rate there in the middle. You'll notice the deep colors are still in the south where that is the high infant mortality rate, but our neighbors seem to be doing a little bit better job than what we are here in Kansas, and so we hope that we're going to improve those numbers by our FIMR programs. Looking a little bit more closely at our Kansas data, and this is through KDHE. This is periods, they do 5-year rolling averages, and so that's important to know that they statistically don't look at a single year. And so the yellow period is our neonatal deaths. They break those down. That would be from birth up until 27 days of age. The post-neonatal runs from 28 days up to 364 days. And then the blue line at the top averages those all together. The good news and the thing to note here is that we, in general, have been going on a slight trend down. Bringing it a little more closely to home here are Shawnee County infant mortality data. The most recent data for the past 5 years has us at a rate of 6.1. That equated to 72 infant deaths. We are one of the 4 leading counties with the infant mortality deaths here in our state. The other counties are Sedgwick, Johnson, and Wyandotte County. And overall, that's not surprising because we also account for the highest percentage of births here. Just real briefly to note, of those 72 deaths, I drilled that data down just a little bit to read. Those causes predominantly were SUID, which is sudden unexplained infant death, prematurity and low birth weight, and congenital anomalies. So overall, the national FIMR program started back in 1984, just to give you a little brief overview of it. It started through HRSA and the Federal MCH Bureau. And it originally began back with 6 projects in the United States. And it's a basic quality improvement model. And we'll see that a little bit more as we look about the process. There was some research done about 20 years after the first FIMR program started by the Johns Hopkins School of Public Health. And these were the things that they found that existed in communities that had FIMR programs versus those that did not. And so those are things that we're looking at as we move forward with our FIMR program in hopes to be able to bring to our community. So I mentioned it is a quality improvement process, and so for anybody who's done any quality improvement, this is the infamous quality improvement wheel, but just with the FIMR process embedded in it. We'll go through each of the steps a little bit more now. So the FIMR process with data gathering. It starts with a notification of death. So we work with KDHE to receive eligible FIMR deaths. So again, they have to meet the criteria that I identified in the early slides. And the other piece is to be eligible for FIMR is that they can't have any legal involvement. We don't investigate any of those cases. So once those cases have been ruled out, we receive the notification of death, and then we start a case records abstraction. So we have registered nurses who look at all different records that would exist on a family. If we have access to the prenatal records, the labor and delivery records, and then if the child lived for any period of time at all, any of those records. We work closely. We have MOUs in place with our hospitals and different doctors' offices here in our community, and also those outside of our community, because as long as a mother has an address here in Shawnee County but delivers elsewhere, that infant mortality rate or actual statistic belongs to us. So after we identify all the cases and abstract those, we use a database that all the information goes into. The unique piece that makes FIMR what it is that third piece here, the maternal and family interview. This is a voluntary interview if mom or her family agrees to do it, but it provides a very, very interesting piece of the case. This is an opportunity for her to share her story of what happened surrounding her pregnancy, of what happened during her childhood, of what happened in general, just about the death of her baby or infant. And so it provides, like I said, a piece that you just cannot get from reading the records. All of that information is then put into the database, and then we get a case summary that prints out. I want to say now that we follow all of the HIPAA regulations. We undergo training where we've presented to the Institutional Review Board because our mothers are considered subjects, so we are following their guidelines also. And all of the information is de-identified once the case summary comes out. All of the names are redacted, all of the delivering facilities, doctors, clinics, anything of that sort, so that there's no identifying information left about this case. After the case summary is then compiled, the first of two teams looks at the information. We have the case review team, and they're really the information synthesizer for the group. They get the information, they look at it. It's a lot of medical staff members on the community or case review team, but we also have a lot of other disciplines also that are interested in infant mortality. They look for trends. They're looking to see if we see anything from one case to the next case, if we identified any gaps in services that may exist here in our community. And throughout the year, they compile recommendations from each of the cases. Right now, this year, we're currently meeting monthly, and we meet for about 2 hours at a time and review 3 to 4 cases every month. So that list of recommendations that they put together, then they come up with one final list of a few things. The list is always longer, and we have to condense it somewhat, and they send to the next team, the Community Action Team. And the Community Action Team is now our Healthy Babies team through Heartland Healthy Neighborhoods. That was a team that was put in place through the Community Health Improvement Plan and was a group of champions and stakeholders already invested in the work of infant mortality here in our community. So last summer, they officially transitioned to become the CAT team. They receive the list of recommendations, and then they really start looking at seeing what's available in our community or maybe what's not available in our community, and how can we get different groups to come to the table and talk more about the issues that are involving infant mortality here in our community. Some of the different action or recommendations that they received are very complex. Again, I stated infant mortality is complex, and so you can imagine that some of the recommendations are just every bit as complex. In conclusion, a few things that I want to point out that FIMR is not. FIMR is not the blame game. It's not a peer review, so it's not doctors looking at each other. It's not hospitals or clinics looking at each other. We don't do any of that. Again, it's a very non-judgmental, non-biased group of people coming together to really look and see the circumstances surrounding the death of this particular infant and what we can do to better our community for it. And there has been a lot of collaboration. Heartland Healthy Neighborhoods has brought together a lot of partners that are invested in looking at infant mortality. A lot of partnerships have been formed because of this, and it seems like every month there's a new door that's opening and we're welcoming a new partner to our table. I'd be happy to answer any questions you may have.
Questions?
I don't have any.
I have a quick question. From what I can gather, getting all this information, and the result of it is these intervention strategies that we talked about. What are some of those?
Well, the intervention strategies, we're looking to see if there happens to be an evidence-based intervention that's already been tried. And so we look at different things throughout the U.S. really that have FIMR programs and seeing if there's different models that they have used to see if there might be an intervention strategy. The other piece about FIMR, though, is that it's very unique to your community. So knowing that what one intervention strategy that may have worked at a FIMR program in a different state may or may not fit our community, depending on what needs we have. So those are really the intervention strategies we're talking about. A couple that we're particularly looking at right now that I can share from, these would be from the 2015 recommendations, involve family planning. That's been an identified topic as we reviewed the 2015 cases, that family planning seemed to be a concern in our community and a common trend that we saw among the cases, meaning there were a lot of unwanted pregnancies and a lot of women that weren't seeking family planning after delivery. And then mental health is the other big piece that we're looking at, and the disparities that exist. And again, a very common trend that we've seen among the cases.
Very good. Thank you.
Thank you.
Anything else? Thank you
Thank
again.
Okay, so next we'll have Ed Kalis come up and talk about the mosquito surveillance program.
Good morning, Commissioners. Ed Kalis with the Health Department. As you have already heard a little bit about today, we have a mosquito surveillance program. We've actually been doing it with KDHE since the middle of May of this year. KDHE had been providing mosquito surveillance with Sedgwick County for a number of years, and what that does is it allows them to kind of get an idea of when the mosquitoes are here. We know West Nile virus has been in Kansas for almost 10 years now. But it lets us know where it is a little bit quicker, and it also lets us know what kinds of concentrations we're talking about. So KDHE got some money through the Centers for Disease Control and is passing that down to Shawnee County, and I believe the other one is Reno County. And both of those counties are using their local staff to help with the mosquito surveillance. So we're hoping that this winds up being a good collaboration. And as far as we can tell, the funding is going to last for a while, but we're hoping the activity lasts for even longer, because we do believe that the data is going to be very helpful. Pardon? Other button? Or I can just do that again. Okay. We have 6 traps in Shawnee County. These are the locations where the traps have been set. KDHE has contracted with what he actually is called is a crustacean taxonomist and ecologist. His name is Dr. Christopher Rogers, and he has been the one working with KDHE in Sedgwick County and with us in Reno County. And what he is doing, first off, he trained us in May. He took all of our environmental health staff, the MRC volunteers, the Medical Reserve Corps volunteers, and put us through a 3-hour training on mosquitoes and mosquito-like kinds of insects. There are about 83 different types of mosquitoes in Kansas, and a lot of people think that they're all bad. And depending on how you look at it, maybe they are. But there are a lot of insects that are not mosquitoes, that people think are mosquitoes. So we learned some things there, and basically the 2 genuses that we're looking for are the Anopheles, which would be the ones that transmit the West Nile virus, and then the Aedes aegypti and the Aedes albopictus, which are the 2 that have been implicated in Zika transmission. So of those 5 sites, or 6 sites, 5 of them actually have traps to catch the Anopheles mosquitoes, and one of them, which is this one right here, that's at the zoo. So that one is designed to catch the Aedes aegypti or Aedes albopictus kinds of mosquitoes. They put it there because a lot of the mosquitoes that we deal with, most of the 83 species, don't really come out during the day. The Aedes do. They're more aggressive. Their main meal is people. It's not other animals, birds, it's people. So they decided to set it at the zoo because there are people probably being bitten at the zoo if they're there. And then in the evening hours when we go to collect the information, they're not just going to go away because the people left. That's where they're going to be breeding for the long haul. All of these, except for the zoo, is on private property. So at this point, we've had a bunch of citizens that have allowed us to do the trapping on their property, and we've been doing it, for, like I said, for about 4 weeks, and we've got some really good data at this point. You've heard before, I believe through administrative communication or through KDHE's press releases, that we have found 2 pools of West Nile virus in our mosquitoes so far. I believe one was in trap number 2, which is in Silver Lake, and the other one I believe is around number 3, which is at the zoo. That can't be right. I think it's this one. Sorry, that would be number 6. So those are showing us that the virus is here. We knew it was coming. We always know it's coming. But what this data tells us is how much, how often, and how soon, which allows us to tailor our educational campaign a little bit easier. Linda promised show and tell. So I brought a mosquito trap this is for the Anopheles mosquito. And so you're wondering, what do you do with a paint bucket on a trap? Well, one of the things that mosquitoes like, and all of the traps have this, even the one with the 80s at the zoo, is a bucket full of dry ice. Dry ice produces carbon dioxide, which is basically our exhaust, our exhalation chemical, and that attracts them to the trap. And if they get anywhere near this area right here, the opening of the trap, they get sucked in through a little fan. And so KDHE has provided us all of this equipment and extra battery packs so we can keep those charged. And then what happens is they get sucked in, and somehow or another they don't get chopped into little pieces. Right now, MRC, the volunteers are the ones going out and setting the traps at night, because the traps cannot be set fewer than 2 hours or before sunset, and they should not be picked up more than 2 hours after sunrise. So in the evening time, the volunteers are putting these out, and then in the morning, the environmental health guys are coming to pick them up. So that's what that trap looks like in the wild. They bring these in on dry ice. They take them into our office, count them, as gently as they can. They pull them from the net, count them, put them in the mail, and then send them to KU, where Dr. Rogers counts them, identifies them, and then sends some of them in for viral testing. On the right there, that's the trap at the zoo, and Perla Hernandez, she is one of our MRC volunteers, and then Quentin Unruh, he is our coordinator for MRC. So he has actually been out there training a number of volunteers to do that work. So it's gone pretty well as far as that goes. So this is one of the traps. The other one, which is a little short, squatty trap, it's a little different. We had it at a dock at one of the lakes, and some kind of animal chewed up the cord, so we wound up putting it somewhere different, and that's where we decided to send it. So it's a different kind of trap. It's a little more bulky. I didn't know if it would go through the security machine. So anyway, this is the majority of what we're doing, which is kind of testing for West Nile. This is what some of the data looks like. This is a couple weeks old, but it has all been very good data. We have had one 80s albopictus, which is of the two kinds of 80s mosquitoes that is the less likely to carry the West Nile. So we have had one sample at the zoo. So it's here. Now we know that they're around. They're potentially going to be coming around, as often, as quickly or as often as the weather allows, or the mosquitoes get closer to here, or if we have a travel case of Zika, if somebody has been infected and they go outside and become a blood meal for some of these mosquitoes, then you can have more of a local pool of those, and then potentially local transmission. But at this point, one sample of one kind of mosquito that really isn't the one that causes most of the issues is just something to watch more than to be a concern. As I said, the information's been very helpful. We've been able to kind of give people a little bit of allay their fears, because they're here. We know they're here. So we give them the advice that they need to keep from being bitten, or to help the mosquitoes not to be able to reproduce in their yard, or whatever it is. We are into the dump day campaign about 3 weeks, and that has gone pretty well. Last Saturday we had a tire disposal campaign, so we're going to wait and see what those numbers were to see how many tires we've removed. But all of these things together all kind of work together to help us reduce the exposure to mosquito bites, and hopefully to reduce the amount of mosquitoes that we have in Shawnee County. So if you have any questions, I'd be happy to answer them.
Very good. Yeah, we had a family friend that had West Nile, and it is a wicked disease. And what's the latest on Zika in our state, in our county?
I don't know that we've had any specific information in our state, other than, like I said, we had one sample, or one mosquito that was caught in the zoo trap that was the albopictus genus. So that's a little bit. It's not the Egypti, which is the one that has been transmitting most of the virus. Okay. So at this point, we've had one mosquito out of however many we have, and the chances of somebody having been bitten or fed on by that mosquito are probably not very high. And even if they were fed on, that doesn't mean that the Zika was there. And we do try to test these for virus, but we have to have enough of them. We have to be able to get that information to be able to give you a good answer for that. But at this point, we're collecting mosquitoes, and the data has been very helpful.
Okay, very good. Thank you. Questions for Ed?
No, thank you very much.
All right. Thank you again, Ed.
And correct me if I'm wrong, Carrie, but we have not had any confirmed cases of Zika in Shawnee County this year, travel or otherwise, so. So now I'm going to ask Dr. Pizzino to come up and talk to you about the county health rankings and what will it take to improve Shawnee County health. Just as a side right here. Yeah.
Thank you. Good morning, Commissioners. Glad to be back here in front of you. Sorry, I think I missed the last meeting of the Board of Health, but I'm here today to talk to you again about the county health rankings. As you know, it's something that we've been talking about for several months, actually for years. There is a report that's issued every year around March and ranks all the counties in the state along their health, some health factors and health outcomes. I know the question has been asked in the past. We get it. How do we improve it? And that's really what I'm trying to briefly address today, my brief remarks. Before I do that, I want to just reframe the issue very quickly. I'm not going to go over all the data that we have already covered during other meetings, but just as a reminder, this is the ranking position of Shawnee County for health factors. So those are the determinants of health, and we will review a few of them in detail in a moment. We ranked in 2017, 78 out of 102 counties were actually ranked in Kansas. And for health outcomes, we ranked 65 out of 102. So we're not at the bottom, but we are certainly not at the top either. And there is a lot of space for improvement, and I believe desire to improve these numbers. The rankings are based on a model that is actually evidence-based, meaning based on research that was conducted in the past several decades. And while many of us and many of our citizens think of health just primarily as doctors and healthcare and clinics and medications and hospitals, we now know that only about 20% of the health of a community can be related to the level of health care that's available in that community. Another 20% is due to genetics. That's more at the individual level. There isn't much we can do about the genes that we receive at birth, although that is changing very quickly. But for now, we will say that there is not much we can do. But 60% of the health at the community level is really driven by social, environmental, behavioral factors. And 60% is a lot. This is the model that the county health rankings is based on. Again, I'm not going to spend much time. You've seen this before, but it shows that there are health factors that are then classified into behaviors, clinical care, socioeconomic factors, and physical environment, that then in turn will drive health outcomes. So let's look at some of these health factors and some of these numbers for Shawnee County. I put in the next couple of tables only the numbers that are the most important in determining the ranking position of Shawnee County in the county health rankings, just because of the way their values stand out among the values of the rest of the state. And you can read them by yourself. I'm not going to go line by line, but this is a county where we have a relatively high level of crime. Unemployment rate, it's just about on average with the state. But we have more than 1 in 3 children who live in a single-parent house. And we have about 1 in 5 who live in poverty. We have a graduation rate that's 80% for high school. And when you put together that number with the percentage of residents with a college degree, that value is 65%. As opposed to a 69% in the state. So I'm probably not telling you anything that's shockingly new. It's a community where there is a pretty concerning level of poverty and lack of education. When it comes to some of the behaviors, the one that really stands out for me is smoking, and you can't really tell too much from this number. Now, last year it was higher. We have 19% smoking prevalence among adults as opposed to 18 for the state. And last year it was, I believe, 20 or 21. But hold that thought, because I'm going to show you in a moment some tables that will give you a better picture of the smoking issue in Shawnee County. We're just about as lazy as the rest of the state, 33%. We have a problem with overweight, and we do have access to recreational opportunities better than the rest of the state, and that's good. And that's actually, in large part, thanks to the work that the county has done in fostering good parks and recreation facilities. Now, the clinical care, and that's a question that's often asked. So what do we do? Is it a problem with our hospital? Is it a problem with access? When it comes to the clinical care ranking, actually, that's the good news in the picture for Shawnee County. We are number 10 in the state, both in terms of access and in terms of quality. There is still space for improvement. I always like to point out, 68% of mammography screening is you can look at the flip number, which means that 32% of the women who should receive mammography screening do not receive it. But it's a respectable number. So this is not the issue. This is not why our ranking is low. It's because of the numbers that I showed you earlier, because of socioeconomic factors. And so I know that the question was asked a couple of meetings ago about Grace Med, and we're all excited because we're going to have a new facility for Grace Med. It's not the one in the picture, but I just put the one there that is very glamorous. And the question was asked, can they make a change and the difference? And my answer is that alone is unlikely to make a big change, because you just saw it. We are already number 10 in terms of clinical care. So I'm sure it would be helpful. I'm sure, and I'm very appreciative of the work that Grace Med does in reaching out to the underserved population. But I think the impact that Grace Med can have with the new clinic is going to be much bigger if they are going to take, and I have no idea if that's their plan or not, but if they're going to take a holistic approach and an integrated care approach, if they consider the environment from which their patients come from, and they try to work with their patients to also address the factors that keep their patients unhealthy, and not just the problem du jour. I'm going to write a refill for your hypertension medicine, or I'm going to check your diabetes. And it's even more important, I think, if they provide integrated care. And there are two issues in particular that are very, very important in Shawnee County and elsewhere in the state: behavioral health and substance abuse. And they drive a vicious circle with all the socioeconomic issues that you have seen a moment ago in my tables. And I will show you an example of that in a moment. But there is another question that I would like to put on the table. Can the Board of Health, can you make a difference? And I have no doubt about the answer to the question, and that's a resounding yes. This board has a crucial role in setting the conditions for our community to be healthy. And you took the first step, and I want to compliment you for that when you decided to meet as a Board of Health. I don't know if you're aware of that, but there are not many counties in the state that have taken the step. It's considered a best practice. It's something that everybody is encouraged to do, every governance body, but it's still not very common. So, we need to recognize your wisdom and your vision when you enthusiastically embrace the idea that was proposed to you. Shall we meet separately? I'm sure that one more meeting is the last thing you want in your busy schedule, but you have been very diligent in holding these meetings. But I'm here to challenge you today to go maybe 1 or 2 steps farther than that, and to embrace the concept of the chief health strategist. And that is someone who doesn't fix all the problems by himself or herself or themselves, but plays a big role in convening, engaging players, and make those players participate in the decision-making process. And to be more concrete and specific, let's see a few action items that could be on your radar screen for the near future. One of the things I would challenge you and encourage you to consider is to expand the Board of Health meetings. And I know this is a public meeting, and we see a good audience here, but let's face it, we meet in your chamber at 9 or 10 o'clock on a Monday morning, and in many cases, I'm going to be blunt, we talk to ourselves. And that's good, but it's probably not good enough. If you want to get at the root of the problems that I showed you in the tables before, we need to have people here like the county department heads. We need the city. Where is the city? About, is it 2/3 of our county residents live in the city of Topeka? There isn't much, and again, I will show you in a moment, there isn't much that you as a county commission or even a county board of health can do without the participation of the other policymakers. Law enforcement, the county state legislative delegation. And one last thing, consider an advisory board perhaps. You have the authority to set, you have the legal authority, the statutory authority and the obligation to set policies regarding health in the county. But it's hard to do. That's a lot of responsibility for just 3 individuals, and with all the other tasks and responsibilities that you have. What's been found helpful sometimes is to have an advisory board. That it's a more comprehensive board where maybe some of these people listed here, some of the entities listed here can be represented. That board wouldn't have any decision power. Would just be there as a resource for you to discuss more in depth some policies, interventions, and then bring them to your attention. And the other thing, of course, support the health department activities that are related to improving the health in the community. And there is a lot of disease prevention policies that the health department can pursue, and some of them are already being pursued. And I want to spend a couple of minutes to talk about legal age for tobacco purchase, because that came up, I remember, one of our recent meetings. And I don't know if you're all aware of that, but as great as that idea may sound, can't do it without the city of Topeka. You can't impose a restriction on home ruling as a county board without the concurrence of the townships, and you can do that in the unincorporated. Now, I'm not an attorney, so take this with a grain of salt, but that's my full understanding. You can do that in the unincorporated areas of the county, but how many resale points for cigarettes do you have in unincorporated Shawnee County? Probably not very many. Most of them are in townships and the city. So a good example of why those partnerships are so important. So let's look at smoking a little bit. The smoking prevalence 2015 in Shawnee County was 22%. This comes from a slightly different source, so the number is not exactly the same that I show you in the county health rankings. But let's break that down a little bit. By income, for example. People who make $50,000 or more have a smoking prevalence of 13%. So only 13% of people who make $50,000 or more report smoking. If you go down to an income between $25,000 to $50,000, it's 19.7%. But look what happens when you go below $25,000, almost 39%. The prevalence of smoking in the United States as a country in 1984 was 31%. So the people who live in the lowest bracket of income in Shawnee County have a smoking prevalence that is much higher than the overall country-wide prevalence that we had back in 1984. It's like decades and decades of smoking cessation activities that were lost in those people. So you see how if you just look at one number, that may be misleading. You may think that, yeah, well, it's okay, we'll do a little worse in the state, but not that bad. 39% is a lot. And then look what happens when you look at smoking prevalence in people with poor mental health in the past 14 days, almost 40%. So back to the slide I showed you about Grace Med. That's a kind of intervention that the safety net clinic can really embrace, and having integrated mental health and smoking cessation programs and good connection with the substance abuse facilities and resources that we have in the county. That's extremely important. Today we can even map these numbers. There are models that are built by the CDC, and so again, this is smoking prevalence by census tract. So the darker, the worse, and you can see how that pretty much overlaps what we know, some areas of Topeka being as those more with low-income people and things like that. So these are all extremely important pieces of information to target our policies and our initiatives. So my conclusion, what can be done? I think the focus has to be on policies and interventions and programs. And the policies that are the most important are those that will attack education and poverty. And I know these are not the easiest, but unfortunately, those are the main drivers in Shawnee County and probably elsewhere for the poor performance in terms of rankings of the county. people who live in poverty and people with less education, they tend to be more unhealthy. It's just, the evidence shows that. It's not unique to here. The other element I would stress is to develop and secure skills through the health department. You have a lot of very valuable and extremely talented staff. But I'll be blunt with you again. I think I owe you this as your health officer. There isn't a single trained epidemiologist in the county health department in Topeka. Not a single one. There are health departments, urban health departments in the state that have a full epidemiologic unit. We do not have a single trained epidemiologist. We have a lot of great case investigators, nurses, people who know a little bit of epidemiology, but we really don't have staff trained to do the kind of work I show you. When you look just at smoking prevalence and then you break it down by groups and you dig deeper and deeper and deeper, that's the kind of analysis that we need. So we know where to target those interventions. Same thing for the community outreach, a community health planner. That's a person, I think that Missy's presentation was very much on target. We need someone who can actually work with our wonderful volunteers in the community, volunteer coalitions and organizations, to keep them together, to keep them coordinated, to help them move in a strategic way in the same direction. And that position is still not available in Shawnee County. And the last bullet, unfortunately, is a reality. Be ready for a long journey. This is not something that we are going to fix next year. I have no idea what our rankings are going to show next year. I will be shocked if there is a dramatic increase, because these things usually, especially in urban counties like Shawnee County, they do not change dramatically from year to year. What's more important for me is that we are all aware of what the root issues are, and we implement targeted interventions to the population at the highest risk to reduce those drivers that really pull our rankings down. That's all I have for you today, and I hope this was helpful, and I don't know if you have any questions or comments for me.
I'm sure there will be questions. Commissioner Bueller?
Well, it's time to take action. It's time to fill the epidemiologist position, and it's time to fill the health planner position, and that's what this commission needs to do. That is holding us back as a coalition and as a county. We need that expertise. So,
Commissioner Cook?
Those positions may be important. We also have to balance them out with the budget and our budget limitations and what we can do as a county and how we plan. We have to have a strategic plan as to how we proceed as a county. And I think that's one thing that's always guided this county commission, is being able to look and balance our resources versus the needs of the county and finding those needs, much like Vallejo when they were in crisis, being able to come up with the money for that. But we have to balance out our budgetary limitations versus the needs of the county.
and I would
Yeah, of course.
I would challenge that, saying that we have a community health improvement plan. We've done a needs assessment. We have a plan. We have a coalition right here in front of us that's broad. It includes private. It includes public. And that's where we need to partner with them to help us. We have a plan. Everything you've seen today is in the community health improvement plan, and is the Heartland Healthy Neighborhoods is working on it. I think what we need to do is build some more capacity. We need to, this is in the Holistic Strategic Plan, Momentum 2022 for the Chamber, and for the whole community. This is something that we really need to pay attention to, and it's not just health. It is, in its broadest terms, it is education, it is poverty, it is crime. And it's tough. It's going to be tough work, but we've got to pay attention to this, and we've got to take some action, and we've got to contribute some resources to this specifically. It's time to take action. So.
Commissioner Archer, just
Yes.
outside of the health department, I really look at, an probably untapped resource at this point is our parks and recreation. When we consider the number of children that attend our summer camps, looking at the healthy foods, what foods are we feeding them, what habits are we setting at the youth, our swimming, our recreational facilities, our community centers, all of our community centers are located in our primary zones that are looking at, or outside of maybe the central Crestview, are in this high smoking area, high obesity area, And are our community centers doing outreach projects? Are our Parks and Rec doing outreach projects on obesity, healthy eating? And I know that we do have some, but expanding what we have.
I think that's an excellent point, if I may inject. It's a good example of how having people around the same table to talk also about health could help. Because if I talk to the chief of the Department of Park and Rec, his main concern is not health, and he shouldn't be. He's running the parks of the county and trying to do that in the most efficient, effective way based on the policies that this board establishes. But when we bring people like him and law enforcement and other people involved in the list that I showed, and we say, look, you're also a health agent when you do certain things. And you have the interest to have a healthy community just as much as we do. Because a healthy community is a vibrant community, is a community that will grow economically and socially and will be sustainable. So let's work together on that. So I think your example is very well taken.
I might just share, Linda, if I could. This is an example of Heartland Healthy Neighborhoods work. This is the Active Environment work group. And this is the top potato. It's a texting campaign, basically. And if you text the top potato to 25328, every Wednesday and Friday you're going to get a reminder, a text about healthy activities. And this also then ties in with, it's not just healthy activities, but it's tying in with a place. Most often Parks and Recreation facilities, and then how many calories you're burning. So if you haven't heard about this yet, I know it went out to all the work groups and it's getting out more, but this is an example too of just activity and connecting it with places in our community so that we can encourage an active environment.
Very good. And setting the budget is always a challenge because there's so many unmet needs in our community, and it will be again for 2018. And I appreciate the input early, and we're going to have a lot of it to discuss the priorities we have. But there are just a lot of unmet needs in our community that we can't. One thing I did want to talk about is the tobacco, and I'm sure you're right that we can't do anything without the city and the township's help, but shouldn't we be the leader? Shouldn't we move forward? Shouldn't our health director say, hey, let's get the show on the road? It's time. In my view, it's time to address that issue.
I think, again, that's part of being the chief health strategist. I think you have the role.
Well, shouldn't the director of the health department be our chief strategist? I don't understand why we need somebody other than...
I think there is a place for more than one chief health strategist. I think the director of the health department can certainly, and is already doing in large part their role in terms of connection with the community and with other organizations. There are some policy issues, though, that are set at the board level, and the director reports to the board. And so I think there is a space for both of them. I think, in my personal view, it's going to be more effective if this board reaches out to the mayor, the city manager, or the department heads and say, can we have a conversation together? And then the conversation will continue at the director's levels as well. But having a commitment, the policy initiative at the board's level, I think will be extremely helpful. I don't think it's either or.
Okay, and I think that's a good idea. In the meantime, it seems to me we could be a champion on the tobacco issue, and I think we should. Okay? Any other public comments? Or anybody? Oh, Alice is here.
Hello, Alice Weingartner with Grace Med, and I just wanted to acknowledge Dr. Pizzino's comments about the role that Grace Med can have in this work that needs to happen in our community. I would also go as far as to say that the Community Health Improvement Plan and the Community Health Assessment is the master plan for our community's health and well-being, and really needs to be seen as that. We will commit to partnering with the health department and our other community partners to making sure that we can help address these plans. But as Dr. Pizzino very clearly said, The healthcare system is a small part. It's that policy change. It's that direction from our leaders that really will help address those unmet needs in our community. And we're here to be part of that. So thank you, and thank you for sharing that.
Good. Thank you, Alice. Others for public comment? Linda?
Do you have any more comments or questions for me? Or we have a lot of health department staff here. If you have anything you want to hear about, I'd be happy to bring them up.
But it sounds like we've got an action plan. And now we need specific steps. We need people that are responsible, and we need dates that they can be accomplished. And so that would be my closing thought. Commissioner Cook, anything
Nothing
else?
further.
Commissioner
I have
Bueller?
a question. So is that dealing with just tobacco, or is that dealing with health in general?
That would be the issues that we've addressed this morning, health in general, and our community health improvement plan.
Thank you.
Okay, thank you
Okay.
again.
Thank you very much.
Appreciate it. Thank you, Doctor. Boy, our timing was almost perfect. We're spent an hour in discussion, and I will make a motion to come back into regular session.
Second.
Motion made to come back into regular session by Commissioner Archer, seconded by Commissioner Cook. All in favor say aye, opposed no. Motion carries 3-0. And now the next item of business would be an executive session, and I'll make a motion to go into executive session to discuss non-elected personnel for, oh, absolutely. Next item of business, please.
Executive session?
There is a need. And I'll make a motion to go into executive session to discuss non-elected personnel and perhaps items of attorney-client privilege in nature for a period not to exceed 1 hour and 15 minutes. And that is a motion.
Second.
Motion made by Commissioner Archer, seconded by Commissioner Bueller. All in favor say aye, opposed no. Motion carries 3-0. We are in executive session.